It is my very distinct honor and pleasure to introduce our next special guest, Renuka Gadde, who is a recipient of the Rice360 2023 Innovation and Leadership Award in Global Health. I have known Renuka for many years, and she has been such a thoughtful advisor and friend to Rice360. She's one of those people that is a really excellent strategic thinker and very good at helping you just focus in on what your biggest challenge is and think about how to develop a solution. She started her career at Becton Dickinson BD, a leading global medical technology company, in Singapore as the regional director for the immunization business. And she worked her way up into positions of increasing responsibility at BD, ultimately serving as the vice president for global health, where she was very actively engaged and directed a lot of their efforts for strategic philanthropy initiatives, and also was part of their diversity and inclusion working group. She left BD and joined CHAI as a senior advisor. And at CHAI, she's been actively involved in efforts to build capacity, to advance innovative health technologies, and to strengthen health systems in low resource settings. I really can't think of anyone else who is in a better position to provide advice and inspiration to young innovators who want to make a difference in the world of global health. So please join me in welcoming Renuka Gadde.
First, thank you, Rebecca. It's an honor to be here, and thank you for that recognition. But I think it's also a great honor, greater honor, to be here to witness the wonderful presentations that we heard from everyone. The judges had their little side chat, and it was like, well, who isn't good here, right? So it was a day well spent, and so I want to thank you for that experience and opportunity as well. So I thought I'd share with you today my experiences in the global health journey, something that maybe you can learn from, laugh at, or get inspired, either way. So as Rebecca said, I started off with BD in Asia Pacific in Singapore, moved to the US in 2002. But kind of BD was interesting. The generation now will say, why did you stay with one company for 23 years? Are you crazy? And I ask myself that too, right? But BD had this wonderful, diverse portfolio of businesses, and so I kind of hopped around. Each time it felt like a new company, and then global health was my passion, but I'll talk to you about that. In the middle of the pandemic, I switched. It was time for me to move on from BD and make way to the next career who will take over global health, and I wanted to pursue my passion. I think COVID taught us a lot about work-life balance, and joined CHAI, which is, again, at its core, a health access program focused on low-middle-income countries. So today's context, I'll share some experiences on market shaping and access. This is where I spent most of my life in my career, whether at BD or now at CHAI, to say, how do you get these amazing technologies scaled? And scale in the low-middle-income countries is very different from the developed world. So I'll talk to you about, if you look at market shaping, you'll find many models. Gavi's model here, which talks about how do you coordinate between supply and demand, the donor world and the manufacturers. That's intuitively what market shaping is. But in my experience over the years, I call it the P factor and the P factor alignment, where you must have a problem that can be solved with the right product at the right price. Don't forget the politics involved in global health particularly. And do you have the right press, the right program, the right procurement, right people, and the partnerships? And I can tell you almost always, even if one of them didn't align well, we saw that scale just didn't happen. So this is just a good formula, if you will, to say, get your P's aligned as you all continue to innovate and become these future entrepreneurs solving global health problems. So I come from Hyderabad, from India. You can tell my blue eyes and blonde hair, or my accent. But left India in 1997 to join BD in Singapore, where I was the Asia Pacific immunization lead. And I think I picked my global health love and passion right there in immunization as a brand new young mom. The idea that children don't get vaccinated and don't get vaccinated the right way was very compelling. And that kind of taught me on-the-ground public health, if you will. And I moved into the US in 2002, following my husband. He followed me to Singapore, so I had to follow him now when he was moving to the US. And literally knew nothing about the US other than we had some family living here. And I remember very distinctly in my interview, at the end of the interview, a guy asked me, the interviewer asked me, so when did the last time you saw snow? Because the day I came here, it was massive snow in New Jersey. And I really paused and really paused. He said, are you tired? I mean, you're taking so long to answer this very silly question. I said, I really can't remember which movie it was in. So I'd never seen snow before that. So it is a long, interesting journey, and I'll tell you some funny stories along the way. So the funny story begins right here. I barely joined the company, maybe a month or two here in Franklin Lakes, New Jersey, and my then boss called me and said, tomorrow, please keep yourself free because we're going to the Hill for a session and with Russell. And that's how I heard it, a session with Russell and on the Hill. And I didn't want to pretend like I didn't know anything. So I said, sure, but what is it about? And he said, they want to talk to us about unsafe injections in the developing world. And then I got a little nervous. And I said, so we're going to the Hill? Yeah, it's in Washington, D.C., of course. I'm like, okay, now I'm getting nervous. And I said, you know, I don't think I'm the right person. I just don't know enough about the politics here. Why don't you take someone else? Rubbing insult to injury, he said, well, that was also my view, but legal thinks you're the best person to go. So I'm like, okay, I'm not even your choice number one, right? So I said, okay, let me go home and read up about this. And I struggled with Sessions and Russell, and I didn't want to sound so ignorant. But of course, then I figured that Russell's was the name of the building, and Sessions was Senator Jeff Sessions, and I had it all wrong, and I was meeting him and his chief of staff, Edwina Rogers. And I was like, this is crazy, I don't know anything about anything. But I have to say, when I went and met with the chief of staff, Edwina, she asked me questions about medical injections and basically, is it true that syringes get reused from patient to patient in the developing world? What do you know about this? And I knew everything about it. That's one thing that I was like an expert on. I didn't even have to look up at my manager. I kept talking, and she didn't take her eyes off me. And the next day, we come back to New York, and I'm again with my boss, wrapping up, and his assistant comes and says, oh, there's a call from Senator Sessions' office, and my boss quickly said, well, tell her I'm in a meeting. And she says, well, the call is for Renuka. And he's like, oh, and then tell her she's in a meeting. I did. She says she still wants to talk to her. So it was a funny story because how one thing led to the other. And I came out and she said, we want you to help us organize a hearing on the Hill because Senator Kennedy's team is not supportive of this suggestion to fund injection safety under PEPFAR, which is the President's Emergency Plan for AIDS Relief, because they were mixing up the issue with drug use, injection drug use, versus this was medical injections. And what a great honor. And that's kind of when I became so confident in the United States as well, and organized this wonderful hearing on the Hill. I would have never thought that I would have done that in the first 6 months of me moving into a brand new country. But my strength was that I knew who were the experts on the topic. So I mobilized Dr. Yvonne Houghton from the World Health Organization. WHO had done a mathematical model to say how much of HIV, hepatitis B, hepatitis C was being spread because of injection reuse among very healthy populations because of just lack of knowledge or whatever else. And then that led to an unprecedented funding from the PEPFAR program, which is all about HIV And so they funded $15 million for 5 years for select countries in sub-Saharan Africa under a program called Making Medical Injections Safer. So through this story, I want to kind of just highlight the power of P, the politics, and how do you influence the donors to pay attention to a problem that can otherwise just kind of disappear under the discussion. So again, power of data as well, because WHO had that data, a problem statement, and then they were willing to participate. But going back to immunization, where I started my journey as a young mom and in Singapore, that was the time when WHO issued a target product profile, a call to the industry to say, we want industry to develop auto-disabled syringes because children under 2 were testing HIV positive and they were born to HIV negative parents. Clearly then making a case that immunization settings were the settings where you could easily vaccinate one child to the other with the same syringe. And so auto-disabled technologies were technologies that lock upon injection such that you can't reuse them. And very strict TPPs, because even the needle had to be fixed needle. And an ISO 78863 was developed just for auto-disabled syringes. But here's the story. So you'll say there's a problem. You'll say WHO put in a product need, a TPP. But for years after that, and the first study, I believe, was done in Bangladesh, actually, in 1991. And up until 2000, 2002, there was just no uptake for these devices, even though the technology was available. And so that was my other learning. You can have the right product, but the price wasn't right. It was 12 cents because you're talking about a smaller market. And yeah, there was a problem, but there was no program to support it. And then what happened was Gavi got established, the Global Alliance for Vaccines Initiative, which was a multi-billion-dollar initiative supported by governments all over the world. UNICEF came in to become the procurement agency, and WHO really drove the policy along with UNICEF and American Red Cross, mandating that all Gavi procurement was going to be with auto-disabled syringes. And fast-track that to today's context, just BD alone, more than 6 billion auto-disabled syringes were used for immunization, and there have been at least 3-4 other players in the market. So today, auto-disabled syringes has become the standard of care in immunization. So that's kind of re-emphasizing the piece that I was mentioning earlier. And the price, of course, went down from the 12 cents to 3 because volume and scale obviously also drive price down. I'll talk about another example, the COVID pandemic. Today we heard a presentation about the lateral flow tests, but COVID really created a brand new category where none existed for rapid tests against COVID. You know, it was not a norm, and everyone was running to labs for PCR testing. And really, you could do with antigen-based testing. And so here's the timeline. You know, we kind of saw it over the pandemic period, but suddenly in the middle of October 2020, antigen tests came to the market. WHO changed their policy to say you can test with antigen testing and you don't have to all go to a PCR test. And Abbott came in with a price of 5 cents as opposed to a PCR test that cost $35. So here again, we saw that phenomenal uptake of tests, but very fast policies getting into place, new players coming to the market. And the next wave we predict will be a lot around self-testing, because now people are used to, people in the airports, and I had traveled to India in the middle of COVID, and they would like, do you have an RT-PCR test or an antigen test? Was the security guy asking me that question? And so it became like a common language in the world when this pandemic occurred. And now there's a big move to say, how can you look at introducing self-testing for hepatitis B, C, and HIV, or home-based testing, so to say. Of course, I recognize the waste burden and the problem, and you guys are going to solve for it, so there's hope there. And what is happening currently in my job now at CHAI, just to kind of pivot a bit, I don't know how many may have read the Lancet Commission on Diagnostics, a very compelling report, but they kind of shine the light that there is a huge need to for countries to kind of adopt diagnostics in their national agenda. Otherwise, it's going to be really bad. And based on the WHO Lancet recommendation, Eswatini, among all the countries, floated a resolution to WHO to say, we want you to pass a resolution at the World Health Assembly mandating governments to include diagnostics in their national strategy. Diagnostics, just as an FYI, in most times in the developing world, is an afterthought. You just get treatment maybe because drugs are cheap and easy to buy, but you barely get testing. We used to say it's like the Cinderella that never gets invited to the ball. But now with the Lancet shining the light on the issue, there's a lot of movement happening. And the problem that Lancet spoke about is that literally 47% of global population has little or no access to diagnostics, and that just gets massively exaggerated when you get to the primary health settings, where 81% have no access to essential tests. Even HIV and TB and malaria, which have been very well funded globally, even there you see big gaps. So think about NCDs and think about other disease states, newborn screening totally absent, right? So it's a big, big issue, and this is kind of what I'm working on at this point, and very excited that May 24th, we should see the resolution pass in Geneva, which means that the countries will have to come back and report on what the update is, and then there is this other recommendation to say it's time for an international alliance for diagnostics to be set up. We'll see if that happens, but that alliance will then engage academia, industry, thought leaders, donors, so that advocacy for diagnostics remains pivotal. What's also very interesting that I get excited about this resolution, and these are some buzzwords from the resolution, or keywords, is that diagnostics testing will be not just limited to in vitro, but in vivo testing as well. So suddenly we will see ultrasound, X-rays, MRIs, mammography into the mix, as challenging as they are, but this is really much needed. WHO's published data and reports to say how having access to some of these basic MRIs or ultrasounds can solve so many problems, and they actually recommend different levels of health setting should have what they should have access to. However, a recent survey among 14 West African countries shows that 86% of all MRI units were located in 2 countries, Nigeria and Ghana. And most of them, the 12 countries have between 0 and 3. And I was just sharing yesterday that Ethiopia, a country with 100 million people, is now getting their second mammography instrument in place. So there's a long way, and people are looking for simpler solutions, smaller solutions that can that require less maintenance, that can be used in these health settings. So it's kind of hopefully an exciting time for the diagnostics world, so to say. And I feel like the opportunity is now because, again, the resolution will mean that countries have to report back in 5 years on what they've done. It also means that people will be monitoring it, and there is a very robust pipeline of interesting technologies, as you all very well know, and that's the case. So I just want to say the Global Health Journey also brings together people from different walks of life. I've had the privilege of traveling to DRC twice to meet Dikembe Mutambo. He played at Houston for Rockets, and you may recognize that. It's a funny picture, and I have no hesitation in saying that he is taller than me even when he's sitting down, 7'2". But he actually built this hospital in honor of his mother and does a lot of work through his philanthropy. And here was Anne Veneman, who was heading UNICEF in a container lab at his facility. So you need to have these right people as well, because the moment you have a Dikembe Mutambo, there's donors, money flowing in, but for the right cause. So that was quite a unique experience. I also had the privilege of traveling with the former President Bush and his wife in Zambia. At one point, there was this pink ribbon, red ribbon initiative. I really feel that it was an initiative maybe a little ahead of its time. People didn't get mobilized around it the way they ought to have got, but the idea here being cervical cancer and breast cancer need to be treated at least with the women in HIV populations, given the nature of comorbidity that exists here. And now, again, years later, this is coming up, and there's a lot of focus on addressing cervical cancer. Hopefully, there will be that breast cancer focus too, but that was a great experience that I call these little trinkets on my bangle, if you will, that I've collected over the years. Work led us to meet with the Pope in the Vatican, and the Pope holds Vatican sessions on health. He really calls upon industry, he doesn't mind shaming people, calls upon governments to say, what are you doing for pediatric AIDS? Where's your early infant diagnosis? This is where Kara is very passionate as well, from not Western, and very keen on maternal health. Done the walks with the International Council of Nurses because, again, the nurses had to stand in the same line as the patients to get HIV treatment and access. And there was a whole bunch of stigma associated with it. So we established healthcare worker safety centers, which were like a safety net for the nurses and doctors, where they could access their own HIV medication without standing in line with the rest of the folks. But this was done in partnership with the International Council of Nurses. And these are Uganda and Eswatini pictures. We also, USAID, again, don't ever miss these big donors and funders, do a lot in maternal health, do a lot in TB, and we've had a lot of partnerships with them. And my picture here is in Cameroon. The gentleman that you see in the picture is the current ambassador for PEPFAR, Ambassador John Nikengasong. He was at CDC when we made this trip. One of the things that I always say is go into the countries where you want to serve to observe and learn the practice. It doesn't come from just sitting away, miles away, and you have to actually see the environment to develop and design your products. And this is kind of what I think Rice does excellently. And I see from the presentations that a lot of you have actually traveled and been to the countries and settings where you're trying to solve these problems. So again, I would not underestimate the power of partnerships. Global health is complex. Trying to do it alone and solve for it alone will go some way, but if you really want to go all the way, you have to partner with, stand on the shoulders of the giants, and then you win, because they win, you win, and my life has been dedicated to establishing many of these partnerships. Established a partnership with Chai while I was at BD, and so they knew me when I was deciding to leave BD, offered that I should not just stay home and come and join them. So it's really a nice model, I would say, as you're thinking about your own solutions, to say who are the donors, who are the players in the space, and how could you engage with them. And one such journey connected me to Rebecca and to Maria. And this is a saying, an anonymous saying, I think, but my father always said, the temple the teacher builded will last while the ages roll, for that beautiful unseen temple is a child's immortal soul. And I really think you're doing that not just with your students, but with the NEST program, where you're trying to solve problems for the NICU and newborns. And that's one of my favorite programs. So as much as you're recognizing me for a global health leadership, I have to say that you guys are my global health heroes. I really am privileged to know you, privileged to serve on the advisory, and to be here with all of you today. So each one of you is a global health hero as you're trying to think and solve these problems. But my kudos and congratulations to you, Rebecca, and to Maria, and to your excellent team that's pulled together this event as well.
I was interested in when you mentioned the implementation of imaging equipment in low resource settings. What do you think are the most important changes to current designs that you would need to make in order to implement those instruments?
I think one big study on the instruments that people found were that most of them, even if someone donates them, are just lying there, as you all know, because there's a frequent breakdown, and maintenance contracts are very expensive. And so there's no skill in-house to kind of continue the maintenance, and which is a big hurdle. And therefore, and you need a level of infrastructure for these imaging instruments to be appropriately run, and you need training for people to interpret the results. So I think it's a lack of market-appropriate equipment, maintenance, and human resources and training, all three. And there's a whole new initiative to say, how do you skill people, and how do you negotiate maintenance contracts better, or how do you look for designs that are simpler and more robust in these settings? I think those are the trends that I see happening in this space.
Yeah, I'd just like to first thank you for your talk. That was amazing. But my question is related with the need for diagnostics. Do you think that the COVID-19 pandemic sped up the need for diagnostics? It brought it to light, or is that something that we would have kind of arrived at anyways, and there was already a need present before the pandemic?
Yeah, it's a really good question. There was absolutely a need for it from before, but no one spoke about it, and there was no recognition about it. COVID really catalyzed the word test and treat. Though HIV was test and treat, you can argue, but for a common man and for everyone else, for the governments to realize the value of testing, which is why I think Lancet's pushing for both the resolution and the establishment of the alliance, while it's still fresh in people's minds, because this is the other thing about human minds. In a question of time, people will forget COVID and move on, right? The human nature is so resilient, but COVID did, in its favor, with all the challenges that it brought, attention to diagnostics, I would say.
Hi, this is Shababa. Thank you so much for your inspiring talk. I know you outlined quite a few Ps, and I've heard about the 4 Ps in biodesign, where we do products, process, and a couple of other things. And it was really interesting to see politics in there as well, which obviously is very important. As a young engineer who's interested in global health, like a lot of people in this room who has flown here to be here, how do you kind of recommend we get involved in the politics aspect of things to align it in a way where projects are successful and we can make impact?
Yeah, I mean, for the young folks who want to pursue a career in global health, there are so many avenues. And I would say don't get stuck with just your passion or I don't want to work for a company, don't have the no's, because my sincere philosophy is get a footing into a space and then you steer your own career. I mean, I don't think global health is what it is. Global health was established because of a few people like me, right? We kind of made it happen. BD didn't have a global health function, though it's 100 and whatever year old company, right? So I would say you have multiple options to choose from. Joining a private company, joining one of the donor groups, whether that's the USAIDs or the CDCs or the policymakers, offers on the Hill in terms of policy and lobbying and advocacy, and just being there when there's an agency issuing a call to action, to be present, to learn about the issues. I think in whichever track you go in global health, you can't escape the politics. Even if it's not the politics at the level of the US government, you need to have a national government by your side to have adoption and scale. That's the nature of it. I mean, health is used as a as a tactic for diplomacy. So it's always there between the governments, and some people will even go to the extent of saying that ministers and presidents like it because it's also a way to get, it's a voting bank, right? You attract your constituencies by offering health solutions. So, I mean, you can't escape it. So no matter where you are, you can steer yourself to that. But ignoring that or not being aware of that could be a downfall.
I was wondering if you could give us any advice? Because global health has shown us how interconnected countries really are and how these partnerships are powerful. So I was wondering if you could explain us a little more on how solidify this partnership, especially on countries that hasn't been targeted. Because I feel like, how would you see the first step on uniting forces looks like for you?
Yeah, I think in your case, and I'll contextualize the message for you all, I think your product speaks volumes. Your innovation will speak volume. Get your innovation out there, do a thorough assessment of is it market appropriate or not, and let the innovation speak for you. So in words, I would say, and I said this in a meeting yesterday, make sure that your innovation gets the press it needs to. Because if it's great innovation, but it's with you and the world doesn't know it, it's no good. So presenting it out there, going into competitions like you are doing. And there are always baby steps, but once you find the ground, you'll figure out how you would partner. So look for, in your space, who are the donors, who are the funders, who are the stakeholders. Do a stakeholder mapping of who should be engaged and start at that point is what I would say. That's what I did when we started to say, who would be the people we would chase in this very large world. And even if you get one person, or one big name by your side, then you're off to the races.
And as a follow-up, how would you see the balance on the private and public sector, especially since investment in the developing world is pretty lacking?
Define private sector, because private sector is...
the private sector as big companies trying to target these needs.
Yeah, I mean, I think you need both. This is why a public-private partnership is the way to go. One program that CHAI is running with the funding from Gates Foundation and the European Investment Bank is to say, how can you mobilize private sector engagement to solve public sector problems? So you negotiate with the private sector to say, you may have the expertise and the technology, but you got to work on terms that the public sector wants. You are strengthening the public sector mandate, but by collaboration. If you don't have that bridge between these two, you can't have parallel tracks. So you must have a robust private sector. Oftentimes, private sector takes the lead in bringing in technology. The public sector follows. But if you don't have a public sector driving it, then you're not going to get access to everyone, right? So you do need to have that bridge in the link, which is beginning to happen. And there are new models being tested precisely to engage private sector, private labs even, to strengthen public sector labs. So that's a model that will always be there, and it's good to think of it. And I wouldn't look at one sector versus the other with a lens of like and dislike. I know there are some people who would say, never join the private sector, it's all for profit, or join the public sector and nothing ever moves. But I think there's a nice balance between both. You should go where you have an enabling environment, and then you steer your way forward.
Hello. Thank you so much for sharing your story on such a personal level. It was very inspiring. I just had a question about accessible healthcare. We've realized how a lot of low developed countries have such a hard time accessing healthcare that is pretty basic and obviously very accessible in developed countries. I was wondering if you could touch on the complexity that gets added in war-torn countries, as well as initiatives that are currently out there for BD and other companies that are dealing with allowing healthcare access to people living in war-torn countries as well as refugees.
Yeah, I mean, it's a great question, and I'd say not enough is being done in those settings, I would say, and definitely not from companies, because companies you're staying away from a war setting, right? But you do have initiatives that are focused on UN initiatives and various other programs that focus specifically on refugee populations and vulnerable settings. So that typically happens through the UN agencies, to be honest. Or through the MSFs of the world. MSF is another great agency that's looking at health, and it's like Doctors Without Borders, so that's another entity to also keep in mind. But it's mostly dependent on the UN agency or the philanthropy settings who go into these refugee settings and solve for those problems. And therefore, again, technologies that are appropriate in those settings would be highly valued, but unfortunately, there's private sector doesn't really go into those spaces.
For me personally, like rice is definitely on my radar as I'm applying. But yeah, just what are my options if I want to pursue a career that is very similar to yours?
You know, you're already thinking around rice. Rice is great, I have to say that. And I'm not an alumni, so, but I've just being on the advisory and just watching the programs and watching, you know, the faculty here. And I've said this before, and I don't mean to just say it to embarrass Maria and Rebecca, but the NEST 360 program that the Rice University has, I can tell you that even a private sector entity would have probably not been able to address and solve for those problems. Rice's strategy is to go to a market segment that's the bottom of the pyramid, where industry honestly struggles bringing in their solutions because there's not enough profit. But there's a great need. And entities like Chai will come in and say, can we make an access pricing deal so that these markets can be served? But what Rice has done is looking at those needs and looking at how do you tailor and get market appropriate products that can actually serve, build the skill, and stay. So its success is to be fully seen and realized, but the model is amazing for for an academia to take this on. So I think if you're considering Rice, you're already thinking along the right track. I also know that programs, the MBA program in Northwestern is a great one, where they have a global health track. So look for programs that have a global health track. I'm sure there are several schools. I'm not fully aware of that, but I know for sure from Northwestern where they send students into a setting for 8 to 10 weeks, and you come back and you build cases and you solve for. So I think those experiences are, you know, great experiences because you gain first-hand knowledge and you can talk with some authority.
What would you like to share about presentation? Because I think not so much in the presentation like we've had great presentations today, but more like when you present from, you know, to different cultures, using different languages, particularly when you get down to presenting on test results, such as an HIV test or a COVID test. What are your thoughts on presentation and those different cultures, different languages, things of that nature?
You know, it's an interesting question, right? I thought you were asking me about my presentation style, but that's not what you're asking me about. So you have to be absolutely sensitive and account to local culture, without which you would be making a mistake. And it's so tricky. What is very appropriate in one culture may be seen as how could they do that elsewhere? But being sensitive to local culture is very important. I was pleasantly surprised when my travels to Africa, where in Kenya, they wouldn't start a meeting without actually saying a prayer at the beginning of the meeting. And I was like, really? They're going to pray because we're going to teach them how to do safe phlebotomy? But it was a thing, and you have to respect that. And then towards the end, they would again pray, thanking that they had a good day. And there's something humbling about that. Once you understand and you become part of the culture, you focusing your ways of interacting based on that. The issue of stigma and sharing of results is a big deal. And I think it's gotten a lot better. Now, HIV today is no longer a death sentence. And you're seeing countries achieve a 95% survival rate, which is great. I mean, the average life of a Zambian used to be 33 years, which is now completely rubbish, right? It's like the same average lifespan, 70 years and above. But in the early days, stigma was a big thing, and so you had to have confidentiality, sensitivity, engagement, counseling. All of these were very important, significant parts. And so when the continent was hit with COVID, we did not see the same mortality in Africa as we saw in Asia, as we saw in the United States. I think people were a lot more aware. There were a lot more less stigma, so to say, because they were open about it, and a lot more understanding. But having that cultural, so the big issue comes in with self-testing. A lot of discussion among the NGO world to say, if you have self-tests, do people want to report that or not report that? Is there a stigma? Do people want to kind of, take that, oh my God, I'm HIV positive. Now there's a whole new generation, right? HIV's transitioned from one generation to the other. So there's a whole method to say, if you're positive, don't worry, and here's a counseling, there's confidentiality, and slowly breaking that stigma. So having that understanding of what is sensitive, what can be said, what cannot be said, and actually find in Africa there's a lot more progressiveness, and people are very open to talking about issues. It's become less stigmatized, and it's very refreshing, so to say. But to be aware of those cultural nuances is very important. If you go to India, it's a whole hierarchy and bureaucracy that kicks in, and so you have to respect that, and meetings may not start on time and may not end on time, but that's the nature of doing business in India. So again, I'm not saying anything that you don't know, but just shining the light with some personal stories and examples.
You gave some really great advice to people about worrying less about where they go in a position and sort of getting there and then figuring out how to steer their own ship.
Yeah.
Do you have advice about professionally safe and effective ways to steer your own ship when you have ideas, but maybe they're a little bit different than your organization's current direction?
Right. It's a question, and I can tell you the tactics that are used. So find an ally first. Who's going to give you a listening ear? And obviously the person who's going to give you a listening ear has to be someone who has some authority or some power, right? Otherwise, it becomes like a bitch and moan session, which is not what we want. So find a good ally. But also, I think, always think of a win-win. Why is this good for the company? And not just because I love global health, or I love the idea of going to visit a country here. So I think if you position the win-win in your thinking, I've seen that you can pave the way and create programs, even in a corporation that is probably not thinking about global health. And let's not forget, the investors, the shareholders want to know from these companies, what are you doing for low middle income countries? There's a new awareness among stock shareholders who want the CEOs to comment in their investor conferences. So the CEO has no choice. He cannot completely ignore this space either. I think getting them to see the win-win is the big value, and then you can create. And I think people will say, so doing this will mean what to my sales? That's a very typical company question. So you must also be able to articulate the direct returns and the indirect returns. So we always were very conscious about putting a table. No one's just going to say it's great because it's reputational benefit. They'll say that's great, but we've been around 100 years. What's the bottom line? So again, messages like, doing a great place to work, great things for the community, and a great business story. So the triple bottom line messages is what we would play on. But being able to say, doing what we're doing will lead to this many lives, or this is additive, in addition to the sales and marketing efforts, this is the value we're bringing. Because without that policy work, sales would not have happened. And so kind of making those linkages, but quantifying it was one strategy that I had always used.
No matter where you find yourself, you can give. If you have the opportunity to give, you can give your time, your talents, wherever you are. So never think of yourself as like, oh, I gave up on that. And always, in whatever position you are, encourage people in the passion or the areas that you're interested in. So I would just say that to all of you starting out, no matter where you land, you'll follow your passions.
Yeah, I think you've said that very well, really. I mean, even if you were to work in a medical company and a public health world, I mean, you are making an impact. Even if you're working in a non-healthcare space, you're making an impact. My husband would argue that the technology company he's working in is what is making the impact in the world, So you never feel like you have to be someplace to make an impact, right? You're already making a difference. That's a great piece of advice. And I also want to say, when we talk about global health, it's almost always LMICs, but there's enough work to be done even in a developed country. Look at the people who don't have access to health, even in the United States. And if you haven't read it, my favorite read is the book Factfulness. which really talks about how you should stop using this GDP as an indicator, stop using the term LMICs, and really look at the fact that in this new age and world, you can be a very progressive China, and yet you can have populations that are not addressed with essential health needs, just as you would have a category of those, places like New York, Washington, D.C., I think there are 5 states in the United States, which have a higher burden of HIV than countries in Western Africa. So again, just the mindset of saying it doesn't always have to be a low middle income country, and wherever you are, you can make an impact.
I feel like one of the considerations that gets raised when we talk about technologies to be able to bring more private sector to the table is the opportunity for dual use, right? Something that may have, one price point in higher income countries, and it would have that dual use. How, and in your experience, and having been at some place like BD and just now on the other side, how important is that as a motivating factor to really bring private sector along?
I think you've asked many answers to your question. So one model of business is if you have the same product that has a worldwide market, companies always love that because you're not investing in another manufacturing line, you're not making another product for a smaller subset, and you're able to drive scale and volume efficiencies, so your costs of manufacturing are lower. And then companies are willing to subsidize price for the low middle income countries. So that's one model. But there are also very unique models to say market appropriate products. What works in the West does not always work in the LMIC settings. You have different conditions, different levels of operators, different disease states and needs. You have all these NTDs that don't even exist in the developed world. So I think there's also this argument to say you have to be purposefully focused on solving some of these global health problems, because otherwise they become problems of a few and not all the private companies. So the models differ. So you find the pharma companies doing a lot in terms of drugs, but drugs alone won't cut it. You need to have diagnostics. Maternal health, largely ignored, right? Now it's kind of, we're seeing some traction and movement in that space. So I think there's no one formula, depending on the level of funding, and private sector responds very well to global donors. So if there's donor funding that's driving the program, then they will go out and the deals made based on volume commitments, pricing agreements,